Good afternoon, my dear friends from African Network. It's a great privilege for me to address you regarding my experience of kidney transplantation and the challenges we face in the long term regarding the kidney allograft survival. At the outset, I want to thank Dr. Lloyd for giving me this great opportunity to share my experience. This is the hospital where I work. This is called MGM Healthcare, and this is one of the tertiary care centers where we do heart, lung, liver, kidney, pancreas, small intestine, and bone marrow transplantation. This is the book which I edited recently, and our Honorable Prime Minister, Mr. Narendra Modi, has taken transplantation forward. And during his speech, he talked about one organ donor can save 8 to 9 people to get a new life. This is being addressed about deceased donor transplantation. And this book will soon be available on Amazon for other people to share our leader. So the outline of my talk is CKD in India, early detection and prevention, live and deceased donor transplantation current status. Are we able to preserve functioning allograft for indefinite period? Post-transplant diabetes mellitus, antibody-mediated rejection, BK virus nephropathy, graft pyelonephritis, including mycobacterium tuberculosis, transplantation and malignancy, hypertension post-transplantation, obesity and transplantation. This is a publication from Lancet where we looked at different countries, 12 countries in 6 regions of the world. The prevalence of chronic kidney disease in India is shown in this blue bar graph. It's about 17.2%. And this is classified into general population cohorts and high-risk population cohort. On the right-hand side, in the pink, you see the high-risk population cohort. From Africa, we have Egypt in that. So in India in 2022, we did so many transplants. There are 15,561 organ transplants. We are ranked as the 3rd largest transplant country in the world. And among them, over 10,000 were kidney transplants. And among the deceased donor transplantation, we had 2,765 deceased donor transplants. And from them, we had about 1,585 deceased donor kidney transplants. Long-term immunosuppression, tail of immediate gratification followed by frustration. Short-term success, long-term kidney allograft survival, frustratingly not enjoyed a similar rate of improvement. So this is the first successful live donor kidney transplant in India. This was performed on the 2nd February 1971 by Dr. Mohan Rao, who is the transplant surgeon at Christian Medical College Hospital, Vellore, with the nephrologist, Dr. K.V. Joni. You can see him standing there, and late Professor J.C.M. Shastri. This is Dr. H.S. Bhatt, and this is the patient who got transplanted, and you can see the nurses also there. So the kidney transplantation long-term management challenges are immunosuppression and monitoring, contemporary immunosuppression management strategies, immune monitoring and biomarkers, chronic allograft injury. Then you have transplant complications. This includes nephroprotective medication strategies, recurrent and de novo glomerular disease, cardiovascular disease, malignancy, infections, bone and mineral disease, and care of the failing allograft. And the special populations are pediatric recipients and pregnancy and contraception in women who has undergone transplantation. So evolution of immunosuppressive drugs and immunology challenge. So when you look at this publication in NDT, and we are looking at 4 decades of renal transplantation at Christian Medical College Hospital, Vellore. The total number is 2,702. And you can see on the vertical axis, the survival, and on the horizontal axis, you can see the time period. And when you look at that, you can see that in the early decades, this graft survival was low, and it improved in the next decade and better in the next, and the last decade, it is much more better. the survival is much higher. As you can see here, over 80, nearly 90% at 2 years. And what is the HLA matching? And the graft survival is also shown here. So you have low HLA match, that is haplotype match. You have more mismatch. Your survival is less compared to better match. So this is a article published in New England Journal of Medicine by Dr. Sundaram Hariharan, and he has shown the survival of patient survival, living donor, patient survival, deceased donor, rate of death, and in living donor, rate of death in deceased donor. And as you go down, graft survival in living donor, graft survival deceased donor, and rate of graft loss deceased donor, and rate of graft loss in living donor, and this is deceased donor. And here you have the survival percentage on the vertical axis and the horizontal axis years after transplantation. He has looked up to 20 years, and as you can see that each decade there is an improvement in the graft survival and patient survival, both in living donor and as well as in deceased donor transplantation. This was published in New England Journal of Medicine a year ago, and it is worth reading and learning from this. So post-transplant diabetes mellitus leads to decreased patient survival. Allograft survival is decreased. Diabetic disease in the allograft can lead to graft loss. So risks for post-transplant diabetes mellitus are shown in this, depicted in this table. It also depends on the pre-transplant diabetes mellitus. You put the allograft and then you look at the post-transplant, and then you are, what are the modifiable and non-modifiable? Non-modifiable factors are race, genetic predisposition to diabetes, older age group, that is more than 40 to 45, polycystic kidney disease, male sex, and impaired glucose tolerance pre-transplant. These are all non-modifiable factors. And the modifiable factors are obesity and metabolic syndrome and hepatitis C infection. And after the allograft is put in, you have decreased deceased donor, increased number of HLA mismatches can give rise to diabetes, because in this increased number of HLA mismatches, you have to use heavy immunosuppressive doses. And whereas in post-transplant, the immunosuppression, the CME infection which happens or reactivate after the transplantation, hypomagnesemia, and rejection episode, all predisposed to post-transplant diabetes mellitus. So what are the drugs which can lead to diabetes mellitus? Steroids, calcineurin inhibitors, mTOR inhibitors, and each one acts in a different way, as it's shown on the right-hand side, giving rise to insulin resistance, impaired insulin response, increased glucagon production. And as you go to the CNIs, they produce direct beta cell toxicity, reduce insulin expression, hypomagnesemia, and reduce the glucose uptake. CNIs can give rise to hypomagnesemia, and this need to be followed up with magnesium levels and replenishment if it is necessary. Then mTOR inhibitors produce decreased pancreatic cell proliferation, giving rise to diabetes mellitus. So I am showing you a patient who is Mr. B, transplanted 20 years ago in 2003, type 2 diabetes mellitus for many years. When he came, his BP was 130/70, well controlled. His BMI was 24.4. That's also reasonable. He was on sirolimus 1 milligram for 18.5 years, plus steroids and MMF. His creatinine was 1.7 milligram per deciliter. Urine protein was 2+, glucose was 3+, WBC 2 to 4, and RBC nil. Urine BK virus was very small numbers, and biopsy, the immunofluorescence was negative for C40, and the biopsy showed diabetic kidney disease. It is shown here, 20 years post-transplant diabetic kidney disease, afferent and efferent arteriolar hyalinosis, as it is shown here. This is the blood vessel, and blood vessel afferent and efferent, and this is the glomerular tuft, and these are the tubules and interstitium. So one thing you should notice is that most of our patients who have been having a graft for many years, as in this patient, if they are on CNIs, you will see quite a bit of interstitial fibrosis and glomerular sclerosis. As this patient never received CNI, you don't see that on this he received only rapamycin and prednisolone and MMF. So no significant IFTA is seen on the biopsy, which you see here, hematoxylin and eosin. So preventive strategies for the preventing diabetes mellitus include eat more vegetables. The gut dysbiosis also plays a part. Bariatric surgery for obesity can help, definitely. Pharmacological approach include glycemic targets with stringent follow-up to reduce post-transplant diabetes mellitus, insulin therapy with tight glycemic goals, novel anti-diabetic agent, SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, metformin, and immunosuppressive modulations, and lifestyle changes are the most important thing in preventing development of diabetes or in the management of diabetes in the post-transplant situation. Now, let us move on to viruses and the kidney. BK virus nephropathy. It is usually asymptomatic viremia, 10 to 30%. There could be destructive BK virus illness. Allograft nephropathy in 5 to 6% of those with asymptomatic viremia. BK nephropathy, graft loss, 10 to 80% in the infected kidney. The management strategies include reduced immunosuppression, biopsy, pathologic diagnosis, and to look at the risk, clinical management, intra-kidney distribution of the BK virus is patchy, 2 biopsy cohorts with the medulla, and immunohistochemistry for SV40. As you can see here, this cartoon, you have the biopsy here, which has got both cortex and medulla. So on the right-hand side, you can see the biopsy again. So in the cortex, you are not seeing the BK virus, but BK virus infected tubules are seen in the medulla. So sampling is a very important thing in looking at BK virus in the transplanted kidney. So one should look at the maximal depth, length, medulla depth, and also parenchymal SV40T staining for distribution of BK virus. So BK viremia and viruria, 21 years female, 6 months post-transplant, graft dysfunction, is initial serum creatinine was 0.63 milligram per deciliter, rose to 2.83 milligram on triple immunosuppression induction with a single dose of thymoglobulin 1 milligram per kilogram, no viral inclusion body seen, inflammatory exudate, edema, and graft dysfunction. See the inflammatory exudate you can see with interstitial edema. And the BK virus count in the blood was shown here very high in June 22. And BK virus count is seen in the urine is on 5/5/23, and she's on reduced immunosuppressive medication and also on leflunomide. So this is the same patient with the biopsy. You may think that there could be BK virus inclusion bodies in this part, which is not sure unless you do staining for it. Now, co-infection of BK virus and cytomegalovirus in a renal transplant recipients, you can see the inclusion bodies there, and you can see the inclusion bodies here, and inflammatory exudate as seen in this. So you can have both co-infection with BK virus and cytomegalovirus infection. So recurrent renal allograft dysfunction due to ureteric stenosis in a patient with BK virus infection. You can see that there is the dilatation of the pelvic ileal system, the transplant kidney, and you can see there is stenosis there. This was repaired, and the patient's graft function definitely improved after repair of the stenosis. So hepatitis B virus and the kidney, universal prophylaxis with entecavir is recommended in high-risk recipients and should start perioperatively. Prophylactic treatment may be discontinued in selected stable patients, recipients during maintenance immunosuppression, reintroduced when the immune status is altered. For example, if the patient has any rejection and you have treated it with increased immunosuppressive dosage. All immunosuppressive agents in kidney transplantation can be used in hepatitis B positive recipients. Immunosuppression is intimately associated with increased viral replication. Thus, it is important to minimize the total immunosuppression burden long term. So 81% among 63 hepatitis B surface antigen positive kidney transplant recipients that received nucleoside or nucleotide analogs achieved a survival of 10 years, and liver failure is a leading cause of death for this cohort. Virus reactivation is diagnosed by redetection of previously negative DNA using a highly sensitive assay with a cutoff level of less than 10 international units per ml, while hepatitis diagnosis relies on more than threefold increase in ALT levels or an absolute increase in ALT above 100 international units per ml. Antivirals are available to treat hepatitis B. They include pegylated interferon alpha-2, interferon alpha-2, nucleoside analogs, livamudine, telbibudine, tenofovir, candekavir, and adifovir. So I'm showing you a case for discussion. Sibling transplant in February 1992 detected transmission from donor to recipient, hepatitis B surface antigen positive. Viral count remained high using lamivudine 100 milligram a day. Yearly ultrasound of liver and kidney and alpha-fetoprotein estimation showed unremarkable. Immunosuppression included prednisolone, azathioprine, and cyclosporine. The viral load, which is very high, is shown from 2013 to 19, and as you can see that currently the patient is on entecavir 0.5 milligram dosage once a day. He has excellent graft function and he is doing well, but he landed up with another problem, which I will discuss in the following slides. So hepatitis B virus carrier state prevalence is seen in 4% of the population in India. Across treated and non-treated patients, the nucleoside analog treated patients have developed lung, pleural cancer, breast cancer, renal cancer, and colorectal cancer. So kidney transplant recipients showed an overall risk of cancer that was about 3 times compared to the local population, with an overall risk for males about double and for females over triple. Significantly increased risk in both sexes were observed for Kaposi sarcoma, lymphomas, and leukemias. So here is a patient, late onset, late post-transplant HIV infection with BK viremia. Allograft tuberculosis also he had in renal transplant recipient with Kaposi sarcoma. You can see the Kaposi sarcoma here, and you can see the chronic allograft nephropathy. A fragment of necrotic tissue is seen along with an ill-defined epithelioid granuloma and inflammation as it is shown here. So this patient had lost his graft after the Kaposi sarcoma treatment and switchover of immunosuppressive agent and reduction in immunosuppressive agent. So he had a retransplant done few years later, and this is the follow-up of him, as you can see from day 1 to. So you can see that his creatinine trend post-operatively is shown here, and his tacro level and dosage. You can see the tacro. His requirement for tacrolimus was significantly less because of the interaction with the antiretroviral drug. The second transplant was in 2017, and he had a repeat biopsy done after the second transplant. And there are 20 glomeruli. IFTA is less than 5%. And this gentleman is doing very well with a follow-up and using very minimum tacrolimus dosage, not every day. I think maybe once in 2 or 3 days. So post-transplant cancer patient, this is the patient I alluded to earlier, who was hepatitis B surface antigen positive for 2 decades. Detected rectal cancer in 2019, and he is 75 years, doing well. After chemotherapy, he had a colostomy done. Chemotherapy plus 25 sitting of radiation was given. Colostomy closed, repeat PET scan normal. Current immunosuppressive medications include prednisolone 5 milligram, cyclosporine 25 milligram BD, and that is it basically. So you can see the colorectal cancer here, I've shown here with the arrow, and this is the histopathology of the color malignancy shown, and he had complete resolution of the malignancy. I think his malignancy was driven by using nucleoside analogs for basic treatment of hepatitis B. Rare malignancy in the recipient. This hasn't been reported before. This is Mrs. U, 62 years, liver kidney transplantation in 2001 December. She developed post-transplant diabetes mellitus. Graft function, the serum creatinine is 1.4, hemoglobin 7.9, hemoglobin A1C 8.3. She had repeated diarrhea, off and down for 3 months, weight loss of 9 kilograms. Stool analysis was normal. She had a colonoscopy and endoscopy, upper GI endoscopy done. This was negative. She was on prednisolone 5 milligram, azathioprine 75 milligram, and cyclosporine 75 and 50 milligram. And for the PTDM, she was on dapagliflozin, and a PET scan, special PET, that is GA68 Dotonac scan, showed a 14 into 13 centimeter tumor in the pancreas, as is shown here. The Dotonac scan, pancreatic head of the pancreas tumor is shown here. And then we need to do a biopsy. So an ultrasound, endoscopic guided ultrasound biopsy was done. This is a tumor which is shown here, and this is the head of the pancreas. And what it showed was clusters of cells. And this patient underwent a laparotomy and enucleation of the tumor from the pancreas, and also there were some metastases in the liver which were removed. And since it is clustered, and it was decided that reduction of the immunosuppressive agent, azathioprine was reduced to 50 milligram, cyclosporine was reduced to 50 milligram twice a day, and she is doing well. And I hope she will not have any further metastasis or malignancy. And diarrhea has receded, resolved, and she is doing well. So this is a very rare and not reported tumor of a neuroendocrine tumor of the pancreas. So metastatic neuroendocrine tumor in renal transplant recipient. This is another report with the rectal area, the primary tumor, and spread to the liver. So treatment is, one of the medical treatment is octreotide and new dotatate therapy, as both primary and metastatic lesions are showing SSTR expression. So antibody-mediated rejection, this is an example. Miss N transplant in 2022, second deceased donor transplant with only CDC cross-match. She developed antibody-mediated rejection. 8 years ago, mother was a donor. She had antibody-mediated rejection. A delayed graft function, biopsy was done. She was given plasma exchange for rejection. Current creatinine is 0.9 milligram per DL 1 year after the second transplant. Urine examination is normal on triple immunosuppression, including prednisolone, tacrolimus, and MMF. So TCR and ABMR Banff criteria 2018. And here it is shown that when you look at that, you can see the SV40 stain, the immunohistochemistry stain for C4D, as it is shown here. All these, there is a sensitive stain, IFTA and inflammation, and also IFTA and segmental sclerosis and periglomerular fibrosis. So this is a late antibody-mediated rejection, which has happened later on. So this showing focal tubulitis on this, as you can see that, and also glomerulitis is seen, and as per the classification of Banff. Next, clinical pathological correlation of transplant nephrectomies in elusive graft dysfunction and observational study. We did that. A common complication seen with 50 to 86% of kidney allograft is vesicoureteric reflex, which in turn increases the risk of transplant pyelonephritis by 8-fold. So post-transplant recurrent graft pyelonephritis, this is a 60-year-old gentleman, diabetic kidney disease in 2020, and deceased donor transplantation was done in 2020. Donor was a 59-year-old lady, and then he had recurrent post-transplant UTI, chronic pyelonephritis. Current creatinine is 5.74. Renal biopsy showed tubulitis with interstitial nephritis, and initially he had acute pyelonephritis 18 and diabetic nephropathy. BK virus copies are low. Renal biopsy C4D is negative. There were 5 glomeruli. IFTA was 60%, and the Banff classification of the graft is shown in this. So this is what this is on. So he has, you can see that hyalinose of the blood vessel, interstitial fibrosis, and he had recurrent pyelonephritis leading to graft dysfunction. So this is, in some areas you see normal tubules, in other areas you are seeing abnormality. See that the diabetic kidney disease has recurred in the graft. You can see nodular sclerosis there, and also arteriolar hyalinosis. So mycobacterium tuberculosis, spousal renal transplant in a 53-year-old man, diabetic mellitus. He had the transplant in 2012. Wife was a donor. He did very well. Serum creatinine was 1 milligram. He developed pleural effusion. It was a transfer. Mycobacterium tuberculosis for gene expert was negative. For cysteinous RNA, ESR was 36, and the serum creatinine rose to 2.3 milligram. Urine albumin 1 plus RBCs in the urine 20 to 25, WBC 60 to 65, fever on and off on triple immunosuppression, including prednisolone 2.5, MMF 500 and 250 milligram twice a day, tacrolimus 1 and 0.5. Allograft biopsy, 3 urine cultures for Mycobacterium tuberculosis were negative after 8 weeks. 1 urine culture for MTB became positive. Drugs given were ANH, rifampicin, pyrazinamide, ciprofloxacin, and B6. So this is the allograft biopsy of that man, which shows non-caseating granulomatous interstitial nephritis. As you can see here, this is the glomeruli, these are the tubule, this is the granuloma. And what happened while taking rifampicin? He developed acute rejection. Should be remembered that up to 21% of patients who receive rifampicin develop acute rejection. So this man was a victim of that while treating his tuberculosis, and he lost his graft despite stopping rifampicin, and he went back on dialysis. So recurrence of IgA allograft. So you can see that here is a patient with IgA nephropathy who had a renal transplant on 25/10/2017. Good graft function. Microscopic hematuria with protein 2 plus on 4/12/21. This is nearly 4 years after that. Coronary artery disease. He had stenting done in July 2016. Biopsy done on 21/4/22 shows recurrent IgA nephropathy. So he was taking at that time prednisolone 5 milligram, tacrolimus 1 and 0.5 milligram, and mycophenolate mofetil 500 milligram twice a day. So we thought that let us look into, because we had a couple of patients who had undergone tonsillectomy with remission of the IgA. So he had bilateral tonsillectomy done. Current urine examination, protein nil, RBCs nil. It seems that the tonsillectomy has worked for him in the resolution of IgA nephropathy. So this is the picture of that patient showing mesangial hypercellularity with IgA in the graft and interstitial inflammation. So overweight and obesity in transplantation. This is not an uncommon thing. Prevalence of obesity is high among renal transplant patients between 25 and 35. Patients of South Asian ethnicity who had BMI more than 25 kilogram per meter squared had significant decrement in graft survival. BMI followed a U-shaped curve with a significantly increased risk at both the high and low extremes, and the lowest risk was observed in patients between a BMI of 22 to 32 kilogram per meter square. So this shows the publication bias. Can serial EGFR, body mass index, and smoking predict renal allograft survival in South Asian region? So it is very clearly described in this, with the increase in body mass depending upon the age of the patient, and it shows the graft survival, Kaplan-Meier graft survival curve for allograft over 7 years follow-up. And on the left-hand side, you see the body mass index, serum creatinine, EGFR, and glomerular filtration rate. So obesity on any cause should be prevented. These are 2 of my lady patients who had developed significant weight gain after transplantation. As you can see them, both of them, BMI was over 23.9 kilogram per meter square. So kidney transplant survival in age 40 to 60 and over 60. This is one of our publications. Advantages of renal transplantation in the elderly are doubles the life expectancy of dialysis patients. Projected increase in lifespan of 5 years and 61% decrease in long-term outcome of death. 13.3% of kidney transplant in US RDS are older than 65 years of age. Lower incidence of acute rejection in 20% of the patients. So here is the death-censored graft survival of 140 to 60 as shown in the blue lines, and above 60 in the pink lines. And you can see that at the end of 5 years, it is not statistically significant. So the number of patients who were between 40 and 60 were 181, and 44 were above the age of 60. Patient survival is also shown here. It is not statistically significant. At the end of 5 years, towards 5 years, it is 89.2%. And those who are after 5 years, there is a decrement in the patient survival. Overall graft survival is shown in this. Now, prevalence of hypertension in post-renal transplant recipients, a retrospective tertiary case study. You can see that the blood pressure is shown in the vertical axis, systolic blood pressure, and you can see two cohorts. One is without diabetes and with diabetes. So those with diabetes had higher systolic blood pressure than those who without diabetes. And looking at the left ventricular mass index, that is shown on the left-hand side with the mass index. And also, this is the cohort without diabetes, and this is with diabetes. You can see that those with diabetes do have a higher left ventricular mass index, which will influence the morbidity and mortality. Immunosuppression and monitoring, I'll move on to that. Various trials for immunosuppression adequacy were done. This included Symphony trial. I'm not going into detail. Then the long-term trial, then OptiSub trial, and Transform trial, and all these were done. They were used, these trials were done using MMF, tacrolimus, and to a certain extent cyclosporin. So there is benefit trial using belatacept, produce increase in GFR and acute rejections. Then Astellas corticosteroid withdrawal trial produce more acute rejection. CNI to mTOR inhibitor conversion at 6 to 120 months, inferior outcome with eGFR of less than 40 and proteinuria when the conversion was made from CNI to mTOR. CS trial, cyclosporin to everolimus at 4.5 months. It produced an increase in the GFR, but acute rejection episodes were more. Then the BUST trial, belatacept early steroid withdrawal plus depleting antibody induction, no superiority. So balancing risk, chronic alloimmunity versus chronic nephrotoxicity, 145 biopsies over 10 years, arteriolar hyalinosil, mesangial sclerosis, glomerulosclerosis in 50 to 70% of biopsies with tacrolimus. I have shown you earlier on an example of a patient, 18.5 years without tacrolimus with no evidence of glomerulosclerosis or interstitial fibrosis. Short-term control of alloimmunity is critical. Short-term control of alloimmunity is critical. Price to be paid is later nephrotoxicity when you do control of alloimmunity, because you use heavy dose of immunosuppressive agents and they'll develop nephrotoxicity. Early low-dose tacrolimus, first 6 months, C05 versus 8 to 12 nanograms per ml with ACE inhibitors or ARB is equally beneficial with the reduction of IFTA. So mTOR inhibitor to replace CNI for conversion showed mixed results. mTOR reduces skin cancer. Potential protective effects of mTOR are malignancy 40% reduction and mortality 43% with mTOR or conversion versus inferior graft outcome. So this tells you that there's an inferior graft outcome with the mTOR inhibitor, but the nephrotoxicity is higher with CNI inhibitors, and the graft survival is better, but you have to pay the price of nephrotoxicity. So steroid withdrawal and MMF exposure practice in some centers in India. Long-term benefits and risk of steroid-free regimen are unclear. Early increase in acute rejection in steroid withdrawal can a depleting antibody induction reduce that. CNI side effects are post-transplant diabetes mellitus, hypertension, dyslipidemia, neurotoxicity, acute and chronic nephrotoxicity, MMF exposure. Attempts to reduce appropriate dose and exposure have not been fruitful. It is in the OptiSub study. Similar graft outcomes with CNI MMF versus low-dose CNI everolimus. One need to do individualized therapy. Lack of data in graft or patient survival over time with MMF versus azothioprine. So long-term immunosuppressive management remains a balancing act for patient and graft survival to minimize the toxicity. This is donor-derived cell-free. It is not self-free. Cell-free DNA gene expression profile, HLA matching and DSA monitoring will be helpful in immunosuppression monitoring in patients. Personalized approach long-term immunosuppressive therapy should be entertained. Clinical endpoints that includes less than 1 year graft and patient survival and 1 year rejection rates for new immunosuppressive strategy should be looked at. So it's a very successful pregnancy and outcome in a medical doctor 20 years post-transplant, paternal kidney donor in 2000, successful pregnancy in 2020 on low dose steroid, low dose cyclosporin azathioprine, no UTI, normal full-term delivery, no change in cyclosporin dosage, although the cyclosporin levels were low, despite low levels, 3 years post-delivery doing very well. So poisoned organ donors and allograft survival, we have used cobra bite victims who were deceased on a transplant, and cobra bite, it is published in Transplantation in 2010, and we had recipients living up to more than 22 years with deceased on a cobra bite donors. A memorable event organized by Dr. Sanjay Agarwal, the former director of nephrology at IMS in New Delhi, organ donation day at Vigyan Bhavan. And you can see Sanjay Agarwal standing here with Professor P.P. Verma, Jeremy Chapman, who is the president of the Transplantation Society, myself, Sanjay Gulati, and they are giving a plaque to Professor P.J. Kurian, who retired as the vice chairman of the Rajya Sabha, and he brought out the issue of decision on transplantation first time in the parliament in 1992. So I would like to conclude by stating that late graft loss is frequently multifactorial. Mismatch in organ supply and growing transplant demand, use of more organs for transplantation, infection, cardiovascular disease, followed by malignancy, mortality among recipients, patients, older recipient above 65 years, doubled since 2001, even though we were doing more transplants in older age group. Retransplant merit additional consideration for immune assessment. Young female recipients transplantation opportunity for pregnancy, as I have already shown. Recurrent and de novo glomerular disease, bone and mineral disease require multitasking. Successful kidney transplant require a team-based approach. Utilize emerging biomarker protocols specified for immunosuppressive change, increase or decrease. Surrogate endpoints, blood genomic profiling, molecular assessment of biopsy tissue, urinary chemokines, and mRNA, and donor-derived cell-free DNA are emerging techniques to detect early rejection. Thank you for your kind attention.